Now, does that include also clear aligners?
With clear aligners, the novelty is you just have a spare chair, you throw someone some aligners, they wear it, and everything's hunky-dory. The reality is clear aligner therapy is as difficult biomechanically as fixed braces. You need to know what you're doing. You need to know how to get yourself out of trouble. I mean, if you really think that any software in the world can take crowded teeth, get them straight, and then morph it so that that will really what's happened in life, you're kidding yourself. You know that. I teach clear aligners in my program, but I teach it for cases that I know are predictable movements, and we have a parameter checklist for my doctors. You can't just say every case you do can be clear aligners. No way. You know. So is clear aligners more profitable? Well, in the sense that if you pick the right cases, yes, your overheads are quite low in the sense of inventory. I mean, to put braces on, you need the special adhesives, you need the brackets, the wires. For clear aligners, the lab does most of it for you. But the question is, will you rely on the lab telling you what case you can start? Of course not. You need skill for that. So I mean, there's a lot of people out there. I'm trying to think of the guy in Melbourne, John Hagapoulos. I'm sorry if that name is wrong. He's got like a clear aligner study group where he's saying, listen, I don't care which clear aligner group you're with. We're here to learn as general dentists, and we want to teach tips that work with all aligners, like how do you extrude a tooth when things aren't working? You cut the aligner, you put a button, you put an elastic on. These are sort of things that dentists doing aligners need to learn, because unfortunately, the big players in the market, what's their certification program for an aligner? Like, take the dentist's pulse, and there you go. You can start submitting cases. So that's why they're like a clear aligner. Blah blah blah. They had a big symposium last year, and they invited all the big players, and it was hugely popular because when I speak to general dentists and I ask them, "Do you do ortho?" The ones I ask always say yes, and then I question, "Well, define that." And I would say 80% the definition is clear aligners. They say yes, we offer ortho, but they're doing clear aligners. So it is a huge market, but it's a market where you've got to understand that you need good orthodontic skill before you do clear aligners. It seems like the opposite's happening. People are getting into orthodontics with clear aligners. They get burnt. They realize that wasn't an aligner case, and then they want to learn how to do fixed braces. Did you see? So yeah. I'm all for these 2-day aligner courses. Why? As a business model, they put people into my program who get burnt. Right?
What's your opinion on tongue tie?
Look, it exists, but something's gone crazy in the last 2 years where I don't want to offend anyone, but you could almost do a lecture.
They might be, Eric. They might be listening.
Yeah.
So,
what about? I wouldn't want to do a lecture. Tongue ties for fun and profit. How does that sound?
Yeah,
right?
That's fair enough.
There's certain criteria to see whether a kid needs a tongue tie, and I would recommend a guy called Dr. Zaghi, Zaghi. He's got really good stuff on the internet. He runs a thing called the Breathe Institute. He can tell you exactly which kid would benefit from a lip and a tongue tie, right? And I think that there is a need for it, but probably there's too many unnecessary releases. How can I put that? We teach as part of our program. I encourage dentists to get involved using diode laser for the simple cases. But to do the proper cases, it's a surgical technique. And so not getting too technical, but when you start looking at the tongue, most people only focus on the anterior tongue tie. Some tongues have posterior tongue tie. Right. And my role, when I put my sleep dentist hat on, they're the ones that really cause most of the apneic problems, right? So you can release the anterior part of the tongue, but the posterior is still tied. And there's certain criteria and tests you can do for that, right? Mm-hmm. But by and large, and I think dental council, health insurers, anyone who looks at the numbers game would see a spark rise in the number of tongue and lip ties in the last 2 years. No doubt about that, right? Is it because we weren't diagnosing properly all this other time, or is it a bit of overdiagnosis? Where's the thing? I think look at the evidence-based literature and look at the kids who need it. Now, What I don't do, and I'm not saying not to do it, but there's no way in my right mind I would do a baby's lip or tongue tie as a dentist. Okay. Now that's just me talking. Maybe because I'm an orthodontist and I'm not used to, uncooperative patients and bleeding, right? And look, there is a need for babies to get lip and tongue tie if they're not feeding, but on referral from a pediatrician, on referral from lactation consultant, I think if a dentist starts saying, look, bring your babies to me for their first, I mean, like, you know more dentists than I do. What age would a dentist encourage a first dental exam? It wouldn't be birth, would it?
Probably not. No.
No. Right. Well, so there you go. Right. It's a controversial area. I believe in it if it's done properly and it's diagnosed properly. But I also feel that it seems to be that everyone who's got a midline diastema probably needs a labial frenum. That's not true. Everyone who can't lift their tongue to the top of their mouth needs a lingual frenum. That's not true. Let's look at what would be the consequences if you didn't release that lip or tongue tie.